Okay, so talking now about some bleeding in the brain, which is a big concern, obviously.
Yeah.
Blood's supposed to be there, but maybe not there when the way we're talking about bleeding in the brain, right? So a couple different types of bleeding in the brain we can have dependent on where that blood is bleeding into, right? Like where it's concentrated. So we can have epidural hematomas, and so that's going to be between the skull and the duramater. Not uncommon for us to see that with like a linear fracture, so like a blow to the head that's going to cause that bleeding. Subdural hematomas, so that's beneath the duramater but outside of the brain. Again, a lot of the time this is due to deceleration forces, and that's just going to be that shearing, because if we talked about earlier, the duramater is not vascular, but the arachnoid and the piamater are vascular, and so that deceleration can tear those blood vessels, which could cause some bleeding within those areas.
I want to backtrack for a moment
Yeah.
to epidural. It's categorized by a specific sign that is not talked about very often, but those lucid intervals there, right? If you think about it, the anatomy of our meninges, the anatomy of our brain and our skull and how it all works, if you think about that space in between the skull and the dura mater, it's going to take time for that to fill. And if it takes time for that to fill, it's going to take time for that to start applying pressure to the brain. So it tends to be that situation where people take a knock to the head, potentially producing that linear fracture like Chris was saying. But then it's going to take time for that to build. And so they'll pop up and be fine. But it's going to be over the next couple hours, they're going to be very much not fine. And so that's a really important sign and symptom for you to pay attention to. Now, that said, we see people for 15, 20-minute intervals. We may not know, but if they're acting fine and the mechanism seemed bad, you should have that, kind of raising your spidey senses a little bit. This could be a bleed.
And depending on the size of the bleed,
Right.
could be hours, it could be minutes, and we may not even see that lucid interval by the time. They may be lucid, and then we get there and they're unconscious. So that altered level of consciousness is going back to that versus like EMS. Is going to be a big indicator between your simple concussion, contusion compared to these hematomas and bleeds.
Do you think there'd be more of a mentation breakdown before the consciousness breakdown?
What?
Like, do you think they're
Are they going to become confused before they're?
Yes,
before they're-
yeah, I would think so. Yeah, I mean, it's like anything with the brain bleed; they're going to become more and more confused, and then that level of consciousness is going to really start to change. Yeah,
I could say it louder, but there's a microphone. And I don't
it
think
was
it'll
more of a
work.
comprehension issue.
Big words. Flight
Yeah.
paramedic. Huh?
Hey, just because it's got the title doesn't mean I'm
Critical care, baby.
Yeah.
Yeah, and this is one of those things where, again, going back to a good history that we need to ask about, right? Like, if we have that neurological patient that maybe initially it seems like it's a medical patient, but if we're doing a good job with I love AEIU tips, especially for newer providers, right? Trauma's in there. And so if you're going through, you're not sure what's going on, and you ask, like, have there been any falls? Have they had any? And, maybe the family would be like, well, you know what? They were in a car accident like 6 hours ago, but they said they were fine. They kind of bumped their head, but they said they were fine. They were talking to me normally until they went, to go. Yeah, they went to the bathroom, and I heard a loud sound, and I went and I found them on the ground, and now they're unconscious, right? So
I can't tell you how many calls as a flight paramedic compared to a primary paramedic that we see a lot of people hours after a fall or days where they were fine initially, and then we get called and they're intubated and all these things because they had that brain bleed, and that they were fine with EMS, but then they developed that bleed, and just over time their level of consciousness and all that just started to decline. So again, kind of going back to being that patient advocate, we need to know that that's a potential. So have that high index of suspicion and really advocate transport and treatment as far as getting them to the hospital so they can at least get imaging done. It's like, patients on blood thinners, right? They always have that conversation with my patients that, hey, you're on blood thinners, which essentially means you signed an agreement with your doctor that if you fall and hit your head, you're going to the hospital. I don't care how you're feeling, because there's that just high potential for that kind of slow, insidious bleed. So
Yeah. Good use of
insidious bleed.
insidious. Yeah.
I like it.
yeah,
I like it.
that's right. See, come back.
So we talked about the epidural and then subdural hematomas. That may not have a skull fracture. Again, a lot of the time that's just that shearing force that causes that bleed. So it might not be a direct blow.
Your elderly and your alcoholics
Yeah.
very susceptible to those.
Brain atrophy.
Yeah, they have the brain atrophy. And so, because normally we have that cushion, right? We have the brain and then we have the cushion, the CSF and everything. But as that brain atrophies, the space doesn't change. Their cranium's not getting smaller. Their brain within it's smaller. And so there's more room for it to move.
I usually describe it as like, we have our brain and we'll imagine there's bungee cords hooked up to it, and those bungee cords are hooked to the skull. Well, as that brain gets smaller, you're putting more and more tension on those bungee cords, so it takes less trauma to actually rupture one of the vasculature in there.
I like it.
Just a different way of thinking of it.
It's a good visual. And then
Steal
there's
that one. I'm going to steal that one.
Do it.
intracerebral hemorrhaging, and so that's going to be bleeding within the brain. And so commonly, again, shearing forces or maybe some penetrating injury.
It's like a lot of medical ones as well. That's why they worry so much about high blood pressure and all that.
Aneurysms and that kind of stuff.
Yep.
I don't have much experience with intracerebral bleeds outside of spontaneous, just head bleeds, usually aneurysm related.
It's with the other bleeds because it's such a major trauma that you're not going to know the difference between the epidural and the subarachnoid or intracerebral at that point, besides their level of consciousness.
Yeah, and when we start to talk a little bit after this, we'll talk about like the signs and symptoms. And I mean, we're kind of splitting hairs at that point, at least in my experience, between trauma versus spontaneous. Like they're going to present more or less the same. Right?
Exactly.
So you still need to be recognizing that increased ICP from whatever the cause.
You can have a hemorrhagic stroke and you can have a head bleed, and they look the same sometimes.
I can certainly tell you that most of my intubations over my career have been from some sort of intracerebral or subarachnoid hemorrhage. I mean, whether it's medical or trauma. So that level of consciousness really changes a lot with those. So that's that classic, if it's a medical situation, worst headache of their life. I think one of my first RSIs at Ada County was that Cushing's triad, where we walked in. His heart rate's 40, his blood pressure's 240, he's breathing 4 times irregularly per minute, and ended up being a subarachnoid hemorrhage. It's just that classic presentation. They typically will have that when we're talking about those really internal type of hemorrhages.
Right.
Yeah, and then Mike was talking about subarachnoid hemorrhages, and that's just going to be
Subarachnoid hemorrhoids.
Yeah. Well, I edit this, so that might just get edited out. So yeah, that would be into the subarachnoid space for that. And then so we might see like that bloody CSF with those patients, just based off of where that bleeding is and how it's going to present.
I got a story on subarachnoids. So a couple summers ago, my mom was in a car wreck back in North Carolina. It was rainy, poorly lit road, backcountry road. They were driving back from, literally just picked her up from the airport. It was her, my aunt, and my uncle. And my mom was in the back passenger side of this vehicle. So they ended up hydroplaning head on with a squad car, police squad car of all things. And my mom thought it would be a great idea to put her forehead through her passenger side window. So she actually blew out that whole window. There's lots of pictures floating around, big old swollen forehead. She's fine, so all the jokes are free game. There's a lot of beluga whale jokes thrown her way with that big old forehead.
It was rough.
It was pretty bad. And then she also had a cut, so I've been trying to convince her to be a cyclops for Halloween, and she hasn't done it yet.
Yeah.
But she ended up having a subarachnoid bleed. Luckily, there was no skull fracture associated, but that just is kind of pointing to the fact that we have a lot of vasculature in that area. So just because there's no skull fracture doesn't mean they can't have a bleed. She ended up not having any deficits, but her memory's a little bit touched from time to time, which granted,
It's
my
just
mom's
what she
getting
tells
old.
you.
Yeah.
Like, oh, I forgot your birthday. It's the brain bleed.
Yeah. I'll be so mad if she forgets my birthday. Hear that, Mom?
She's not listening.
You don't know.
She forgot you were doing this.
But yeah, it's and that's a bleed that honestly it would be for me if I was responding to that call. One, it'd be my mom, so that's a different perspective. But let's say if it was somebody random, same presentation, the physical signs would be the giveaway, and it's not even so much as it's like, oh, this could be a subarachnoid bleed. It's more of the facts like your forehead's growing a forehead. Like, we should probably go, right? Like, once again, line of sight treatment, if there's enough physical sign there that's visually jarring, probably a good indication to get driving fast, treat with diesel,
Keeping it basic, it's just we can talk all day long about all the different bleeds and all these different things, but it's really keeping it to what are you seeing, what are the signs and symptoms that you're able to determine, and then that mechanism of injury, combining that whole clinical picture is really what it comes down to, and then treating it and seeing it and actually recognizing it and doing something about it, which we're going to talk about next. But
All right, so let's talk a little bit about assessment of head injuries. We're talking about it before, but let's go more specifically. So you guys have a head injury patient or suspected head injury patient. What's your assessment look like? Anything specific for these patients?
Yeah. So when I walk in, I kind of have the same assessment for everybody, but when it's kind of that head injury patient specifically, first thing I do is I'm looking at kind of their level of consciousness. Are they tracking me as I walk in? What is the level of responsiveness? Is there anything I need to treat right away? Like, are they unconscious, prone, right? We need to do something that way right away. But checking the level of consciousness, then I'm going through the ABCs, right? So is their airway open and patent? Do we need to open up that airway and suction anything out? Head injury patients are notorious for vomiting. So is that something that we need to treat right away? And if they are vomiting, I'm going to start keeping them on their side. Breathing wise, what's the rate, rhythm, and quality? Just because, as we've kind of talked about, the changes with respiratory patterns with increased ICP and head injury patients, that can change pretty rapidly. So not only am I worried about their initial respiratory rate, I'm going to keep reassessing that pretty constantly. And then from there, it's, what needs to be done now, right? We're trying to avoid those H-bombs, so I'm going to get oxygen on them. I'm going to ventilate them with the BVM if I need to right away. And then after all that kind of initial steps are done, if there's anything that needs to be done initially, then I can get into kind of my overall assessment. So with head injury patients, I'm really looking at kind of that mechanism overall. What was the cause of, why are we there today, right? Is this a rollover with ejection? Is this, did they get kicked in the head by a horse? What was the mechanism of injury? And then I'm going to start looking at things like pupillary changes. Are their pupils equal and reactive? Is there one that's bigger than the other? Is sluggish to respond overall? Looking at kind of reassessing their mental status consistently. And then after that kind of initial assessment, I'm worried about things like vital signs. So looking at their heart rate, blood pressure, SpO2, and especially looking to see if that heart rate's trending downward and then that blood pressure is trending upwards. That's really what I'm going to be concerned about. And then after that, it's just, treating the patient as it comes. And so it kind of depends on every patient a little bit, but that's kind of my very basic approach, that initial few minutes.
Yeah. I think you brought up a good point with the pupils, right? We didn't really talk about it during any of these, but those pupils are going to be really, really telling.
Yeah,
right?
definitely.
Justin.
Carry a guide, by the way, to any new providers, because we're awful about determining actual size of pupils, and we all think we're really good at it, but we're not.
Yeah, just have a lot of pen lights.
Same with respiratory rate.
Dude, I'm pretty good at it. I don't know what you mean. Yeah. You mean it's
16 a
not
minute.
18?
You go from 16 to 18, so QA is not on
But you
yet.
got to do back and forth, so it's not too consistent.
Yeah.
But yeah, pupillary responses, that's going to be the big one. Justin, the guy who owns IMA, he, if you guys don't know who he
And
is.
Justin, we trust.
And Justin, we trust. He told me one time, the eyes are the window to the brain. So you want to know what the brain's doing, look at the eyes. And so that blown pupil is really telling. I do have a story with blown pupils, though, about confirming history. It was a fall patient. I just didn't think to look at his eyes. It seemed very clear-cut, straightforward until we got to the back of the ambulance. And then I really looked at his eyes and saw I think it was his right pupil was blown wide open.
What do you mean by blown, for anybody that may not?
Blown pupil, one dilated eye in comparison to one that may be reactive or some other sort of pupillary response. But his right pupil was blown wide. And so immediately I'm like, I missed stuff. So I got to start backtracking him, asking questions. And then he cut me off pretty abrasively and was like, if you're asking about my eye, which I had been asking directly, so that should have been maybe concussion thinking anyway, backtracking. He's like, you're asking about my eye. I got hit by a rubber band when I was a kid. It broke my iris, so it just doesn't work. I was like, oh, okay, right? But that's something worth
Tube in
noting.
hand.
Yeah, I know. I was like, all right, buddy, you're sleeping here soon. No, it's just something worth asking in the history, right? Like, just because you see a sign, yeah, it might line up with something, but let's confirm, right? If they're oriented enough to have conversation, let's just confirm it. But what's the end of the day? You wasted, 5 seconds?
Yeah.
Yeah.
Well, the eyes will show you a ton of stuff because you can get really in detail, and then you have that doll's eye, right? Mm-hmm. So you see those really creepy ceramic dolls that are supposed to look right. You move them and they follow you or whatever. It's terrifying. You have one that those are fixed, like you move their head and it kind of stays with it. I think that's kind of a lesser injury. But if you have one that stays kind of pointed straight forward or goes against where you're moving the head, now you've got a bigger issue. So you can start looking at a ton of stuff in the eyes as far as brain injuries go, and it'll show you some pretty good information.
And then GCS, kind of back to it. This is, everybody hates doing their GCS score, and it's one of the biggest things I think even going through as a paramedic. It took me so long to like figure it out. But get a GCS score early, and then repeat your GCS score throughout your entire time. It's not really, I mean, it is for us a little bit, but you got to think of from the hospital. If you're going to a major trauma center, how many patients they see every day, and you're trying to tell them if your side of the story, a GCS is a very objective way of portraying that patient's status to the hospital, and then for the neurologist or whoever, the surgeon that may be taking care of them down the road, so they can really look at the GCS and trend that over time. So that's really an important
Have
thing.
you heard that thing about patients changing their stories 3 times from time with EMS to admittance to ICU? So on average, patients will change their story up from what we find to what they're going to tell the ER to what they'll tell the ICU. And so AVPU can be actually kind of a disadvantage there, right? Just because they told us, I mean, we all have had that patient, you brought them in, like, it looks like a stroke. When you show up, it's a TIA, you feel dumb talking to the doctor, right? Like, I swear he was stroking a second ago. That could be the same thing with A&O, right? Just because they answered questions appropriately with us, even before and after transport, like to the point, like as we're in the bay, we run one more maybe. It's not uncommon for them to change that answer while they're in there. So GCS could be a better objective way to look at that instead of having to focus so much on what their alert and oriented status is per their own mind, right? We can objectively find it. And that just kind of piggybacking your idea, or your thought, it's just a better way to do it when in doubt.
Yeah.
Yeah. Coming back to eyes too, I had a really good patient once. We were talking about like a fixed gaze, right? That's something that we really need to look at. That was like, I think we just done a training recently about strokes, and there's the VAN assessment in strokes that has vision. And he really threw me off because he was laying on his left side initially, and he was very minimally responsive, but I opened his eyes to look at his eyes, and his pupils looked fine, and he's laying on his left side, and it looks like he's looking up at me. So I was like, eyes are good, until we get him in the back of the ambulance and notice his left side seems kind of flaccid as we're looking for an IV. And then I open his eyes again, and he's still laying flat now, looking only to the right side, and he wouldn't track or anything. So that fixed gaze can be a really, really good indication of some serious head injury
Definitely.
or brain trauma.
I've had the same kind of stories too, of where it's like a seizure. We see that pretty often as well, where we have that increased intracranial pressure can lead to seizures, altered mental status, that kind of thing, and can also lead to that fixed gaze. And I have one where the guy was seizing. We got there after he was done seizing, and the only thing that was really odd with him was he had a fixed gaze off to the left, and I picked up on it, and I was like, that's not the usual postictal kind of phase, and ended up being he had a brain bleed on top of his hyponatremia seizure history, and so he had the fixed gaze because of a brain bleed going on. He was an alcoholic, and kind of that increased risk.
Yeah, a lot going on.
A trick I try to teach my trainees is a lot of times with strokes or people with some kind of altered mentation or something. A lot of people, they want to go to where the person is looking, right? Like you want to have that eye contact and do all that kind of stuff. A lot of newer people will get right up in people's faces. That's really easy for people to track, right? They have a fixed whatever. So what I'll do is I'll stand off to kind of a side, and then as I'm talking to them, I'll kind of pace around and go to the other side. And if they're able to track me going both directions, I'm not as worried about it. But if you stay stagnant in one spot, if they're fixed off that way, then you can't really tell.
Yeah.
So I'll try to get some kind of response on either side, and then I can kind of get that assessment done while I'm multitasking other assessments.
Yeah.
Are they staring because they like you, or are they staring because they got a brain injury? Who really knows?
So what happens if you go to the other side and they look away from you?
And I go, snap a little bit sometimes, you're like, hey. And then they're like, who's doing that? And I'm like, oh, shoot, we gotta go.
Yeah, when you find that neglect side, you're like, uh-oh.
Yeah.
So one thing we've kind of talked about a couple times a little bit in passing, but let's talk more specifically about is going to be Cushing's reflex, or the Cushing's triad, right? So I'm pretty particular about this. because I hear most people say hypertension, and it's not actually hypertension. And so this is where we want to be.
I say it.
You do.
too.
You
Yeah.
would.
So it's not actually hypertension. We want,
Pulse pressure, sorry.
we want to think about it's increasing pulse pressure. And I like to say that because, say all the time, like one set of vital signs is great, but it doesn't tell us a story. We need multiple, right? And so if we think about increasing pulse pressures, to me, it's showing more over time. We can see that change.
Can you
So
break down what a pulse pressure is?
yeah, pulse pressure is going to be the number between the systolic and diastolic pressure, right? So how far apart those numbers are. So as that expands, we'll see that increasing pulse pressure. And so, hypertension can come from a lot of things, but typically in a head injury or Cushing's, we're going to see a high systolic with a fairly normal diastolic pressure. So I like to really hone in on that just to make sure that we're looking specifically for head injury symptoms, right? And this can be that widening pulse pressure. And the way I've always understood it, maybe you guys would have a better way to put it, is essentially the cranium is a closed space, right? As we all know, we've talked about. And so as that closed space starts to fill with blood or whatever it is, the body is increasing the systolic pressure to maintain perfusion to the brain tissue, right? And so that's why we see that hypertension start to happen, that higher blood pressure systolically, where the diastolic isn't really changing because it's not a systemic change like you would see in just a normal hypertensive patient. So I don't know if you guys have a better way to put that. That's my easy kind of layman's visual.
No, that's a
of
good
it.
way of putting it. Yeah.
Yeah, trying to push into that space that has less higher pressure, so we need to increase the pressure, the flow into it. So we got that widening pulse pressure, and then we've got, I think Ali was talking a little bit about the respiratory side of things. We're going to see a couple different specific respiratory patterns, right? So we're going to see biots, which is just kind of like willy-nilly.
ATACs.
I feel like I see that a lot
Yeah.
more often when I think back to my patients as opposed to like the Shane Stokes. That's just that irregular, erratic, almost respiratory.
Like irregular
Yeah.
kind of respiratory.
Just all over the place. And
Yeah.
it's not an adequate ventilatory pattern. That's
Yeah.
really what it comes down to. It's not adequate, so we need to recognize that.
Yeah. And then Shane Stokes is going to be, I think of it visually like peaks and valleys, essentially, where they're going to breathe harder and faster and harder and faster, and then it's going to peter down to periods of apnea, right? So those are both, I feel like when you're brand new, recognizing respiratory rates and patterns is really difficult, but once you've done it a while, it just becomes second nature. And I think that's one of those like sixth sense that we have where we'll recognize that that's off pretty quick, and then we'll turn our brains onto it and be like, oh, that's Shane Stokes, or that's biots, and that's something bad.
I definitely had that moment, and I think I even said it out loud of, oh, that's Shane Stokes. It was the first patient I'd ever seen it on, and it was literally an aha moment for me. And it's one of those, once you see it, then you can start to really recognize. I probably had missed it in the past, but it was like the first time I had actually recognized it on a call. And then once you recognize that kind of thing, it just takes just seeing it again and again, and just takes time on some of these things.
It's like when you see a celebrity. Like,
Yeah.
oh, Shane Stokes, wow.
Yeah.
I usually, when it comes to like the irregular respirations, I lost my train of thought.
Good job.
Head injuries, huh?
Well, I mean, if you see a good Shane Stokes, it'll make your butt pucker a little bit. Like you got someone who just stop breathing, and then you do the whole look, listen, and feel, and then they go,
Hey, man.
Yeah.
I remembered my thought. So how I normally teach it is like, you guys have been people long enough. You know what normal breathing looks and sounds like. You know what it looks like. You shouldn't hear it, right? You know what it sounds like. And it's not so much that you can't identify when something's different. It's, are you choosing to hone in on the things you need to hone in on, right? Like, it's really easy to identify an abnormal breathing pattern if you know what breathing looks like, which if you're a human for 15 plus years, hopefully you figured that out, right? Hopefully. Yeah. But it's the choice of, okay, I know this is potential based on my mechanism. I got to pay attention to it, right? And even if it's paying attention, okay, it looks normal. Okay, as we reevaluate, let's double check on that.
Yeah.
Yep.
And then talking a little bit back to the A&P, right? What we were talking about, the brainstem is what controls our functions such as respiratory rate. And so it's just once we start to see these irregular respirations, it's typically that pressure is pushing physically on the brainstem, right? And so that's how it manifests, and that's what we're seeing, but that's what's going on beyond what we can see is that increasing intracranial pressure, which also is going to cause our third sign of Cushing's triad. which is going to be the bradycardia, right? So
Yep.
I don't know about your guys' experience. I had a really good one a while ago. It was actually that guy I was talking about with the fixed gaze, that he was showing all the classic signs of Cushing's. And so when I dropped him off at the hospital, I asked the doctor, like, do you have, in your experience, is there one sign you start to see first? And he said, from his experience, typically heart rates start to drop a little bit before he sees other changes. I don't know if you guys have ever heard anything along those lines or any experience with that. It was just kind of a curious thing that I asked him.
Yeah, I don't know if I could think of the last one. Her heart rate got down into the 20s, but it was, I mean, that was like peri-arrest kind of. I feel like I've generally seen the blood pressure first, but most of the time I feel like it's already all happened. You know.
Well, yeah. It's just what's going to manifest first.
I've only had one that I can. Oh, sorry. Go ahead.
Oh, so the one that we had, we got called to just kind of a sick person, nausea, vomiting, right? She didn't have any complaints. She got off work, felt a little nauseous with a headache, went home. Her mom came over to check on her, and she's, doing what every sick person does, is puking into a pot, right? Mm-hmm. Looks kind of like garbage. Her heart rate was a little on the slow side, but then it was that vagal response from vomiting, and she's uncomfortable. Her blood pressure wasn't terribly hypertensive or, had those widening pulse pressures, but she was relatively altered. But the thing that kind of threw us through a loop was she had pinpoint pupils at that point. So we were thinking more of a narcotic overdose. Mm-hmm. So she had enough shift in there that it caused some of these signs to be bad. But as when we asked her what year it was, she said like 1932 or something. And I was like, no, wrong.
Let me check my watch. Oh, no,
I think
you're
it's
wrong.
the pons.
The pons,
yeah. When there's compression on the pons, it causes pinpoint pupils as opposed to like our classic head injury signs of either sluggish or one pupil being bigger than the other.
The pons can also control that respiratory rate.
Yeah.
A little bit. So that's those baroreceptors.
Yeah. See, it goes back to anatomy and physiology. That's why it's important sometimes.
Yeah. I mean, in my experience, I don't have any it wasn't true trauma for my Cushing's. It was a spontaneous head bleed. And it was more so I'm starting to think stroke because there was no trauma really following, even though the guy did seize and potentially, I think he fell. I don't know if he hit his head. I can't remember. But I noticed Cushing's more of as well, would you look at that? Because his blood pressure was starting to skyrocket, which is confirming. We'll talk later, I'm sure, about confirming of a stroke, that high blood pressure. So I noticed that, and then I looked down, and he's like, well, he was at 90 beats per minute. Now he's down to 60. His breathing was becoming more erratic. Fortunately, we were literally across the street from the hospital, so I didn't have enough time to really truly manage this patient. I had enough time to get a line and get him on oxygen and we're across the street. So for me, it wasn't so much as an identifier. It was more of look at that. There it is. So just paying attention. It's not about gathering information. It's about analyzing the information we've gathered.
Yeah. Don't just stop at gathering.
Right.
Think about it, right? And that's what's fun about this job is taking all the pieces and doing the detective work of what do these things mean, and then going from there. Maybe it means nothing, or maybe it's because they're bleeding in their brain. Right? Could be anything.
And you have anomalies all the time. Just people anatomically physiologic. We all work similarly, but everyone's kind of different. So what's weird for us presentation-wise could be something totally normal for the patient.
Real quick, to go back to something Ali was talking about, just for people that might not know, the vagal response you were talking about. We have the vagus nerve. It's one of the cranial nerves.
10.
And when, cranial nerve number 10. And when that is stimulated, it causes our heart rates to drop, and it can cause blood pressure drops. So that's not uncommon when somebody's vomiting for us to see the heart rate drop a little bit too, because they're stimulating that vagus nerve with the retching. One of the things that we do as medics for somebody with a really high heart rate in SVT is to have them bear down like they're having a bowel movement, because that stimulates the vagus nerve, and vomiting will do kind of the same thing. So I think we've covered most of the signs and symptoms. One other thing that I've seen personally that I think is really late stage that's very uncommon that we see in GCS scores is going to be posturing that we don't see very often. Maybe initially during a head injury, like the fencing pose, you might, if you watch UFC fighting or boxing or whatever, you might see him posture and it goes away. I've only seen it once in the field where it was actual posturing from a head injury. Well, either spontaneous or head injury. We're not really sure. She was side of the road, driving her vehicle. She kind of like it was a slow speed thing. Like she tried to pull off and we kind of bumped up the curb and she was stopped there. And we got there and initially PD was first on and they were talking about the drunk driver. So we were being led into believe we were just on like somebody drunk driving. But we got in there and we noticed it didn't really smell like alcohol. That just didn't fit. But so she was GCS like 3. So we load her up in the ambulance, C-collar, whatever, get her loaded, get in the back of the ambulance. I was an EMT at this point, so I jump on to get the blood pressure. The medic I was with was doing his thing. And I'm like smelling as I'm like getting the blood pressure ready. He was like, do you smell any alcohol? They kept talking about how she was drunk. And he was like, I don't smell any alcohol. And so I get the blood pressure and it was like 240/80 or something, like really, really high. And it was at that point where we both looked at each other and he like looked up front, the fire guy that was up front, like, go now. And so code 3 to the hospital and halfway, she just like a zombie, her arms just raise up and do like that posturing. Her head kind of goes down and she just stuck like that for the rest of the transport. And so I don't know the science behind this, if this is true. I've always heard that typically posturing is a sign of the brainstem herniating through the foramen magnum. And so that can be a really, really late sign of these head injuries and the increase in intracranial pressure.
I've heard that too. Yeah.
I think when we talk about posturing too, it's kind of important just to note for listeners, viewers, BLS providers, but there's the 2 types, right? Decorticate, decerebrate. Decorticate, they're going to be basically flexing towards the body. Decerebrate, they're flexing away. Now, the way I think about it is there's kind of a level of severity between the two, right? Decorticate's going to be our less severe. Decerebrate's going to be our more severe. End of the day, they're both bad. If either one's happening, they're both bad, right? But decorticate, when they're flexing toward their body, the way I remember that it's not as bad as if it's flexing towards their core, they're still attempting to protect themselves.
Yeah.
Versus decerebrate, they start flaring outward. They're no longer trying to protect themselves. That's going to be the point where, okay, we've needed to be involved. We got to get going.
Yeah.
Yeah.
Yeah, and that's good to know so you can remember the sequence of GCS scores. And I always remember core towards the core. Decerebrate's the other one.
Yeah.
So therefore it's away from the core.
Yeah.
Essentially.
You know one,
the
you
other
know the
one.
other.
It's not core, so.
Yeah.
And then I think kind of last thing to talk about is treatment of head injuries, which not a lot. Go fast.
Management.
Yeah.
Basics. Yeah.
Airway management would be a big thing, right? Like making sure we're suctioning because like we talked about earlier, vomiting is a common thing for these head injured patients.
Watch out for seizures,
Yeah.
super common. So if they do start seizing, keep them on their side and try to keep that airway clear as much as you can. Suction, head to bed, elevated if possible. 30 degrees is kind of the way they're going towards it. And I talked about C-collars earlier. There's a lot of research coming out talking about C-collars causing increased ICP. It's been out there for a while, but there's a big movement in EMS, and I would imagine in the next 5 to 10 years, C-collars are going to be very different than what we do right now. So for now, obviously, still throw them on, but just know that C-collars may be doing more harm than good in some instances. So
I think that's been the shift for a while.
yeah, it's finally just starting to actually make it to like, where people are actually getting rid of
To
them.
the decision makers.
Yeah, they're a little behind the times sometimes, but
Same with backboards though too, right? Like we're doing more damage with backboards. So it's kind of par for the course with EMS. As long as we're growing, we're getting better.
And then, I mean, as a EMT basic, if you have options on hospitals, take them to the trauma center. Obviously, I think we sometimes forget, depending on where you're working, but, it's either a local hospital or a trauma center, take them to that trauma center because they have the capabilities. Keep in mind your resources available on scene if you're way out in the middle of nowhere. Just think of, flight teams.
Call for
But,
Mike.
yeah.
I will
Shameless
never.
plug.
Yeah. Well, if you called me one day, I think we have a problem. Yeah. But yeah,
Probably
just
me.
think of like your resources available and call for them early as opposed to waiting until you're like behind the 8 ball.
Yeah,
So,
you can always cancel units, but it's harder to get them en route.
exactly.
Yeah. And then, always think about ALS in general if you're a BLS provider. But to be fair, there's just not, other than maybe like intubation and stuff, there's not a lot more we can do for these patients. So it's a thought, but I mean, I wouldn't say generally to delay transport or anything in favor of waiting for ALS. Like,
They can meet you en route somewhere too, right?
Yeah.
And especially if it's a long transport.
Yeah, and then
And
what are
they're-
the options too?
Yeah.
Like if it's a 15-minute rendezvous, but we're at the hospital in 20, is it worth stopping for that 5 minutes?
Right. Don't delay your care. I mean, we talked a lot about all these different things, all these little, halo tests and all this kind of stuff, but don't delay your care on scene to try to figure out exactly what's going on. We really are trying to keep it simple, treat the ABCs, and be prepared that these patients are going to deteriorate very quickly. And we've all seen it, that patient that goes from talking to seizing, vomiting, all that stuff in a matter of minutes.
Cool. Right on. Well, I think that was pretty good kind of talk about head injuries and what to look for, what to expect, and kind of how those all work. Any last thoughts from anybody? No,
I don't think
Not
so.
really.
Cool. Right on. Well, thanks for watching or listening, whatever you're doing. We're all over. We got Instagram, Facebook, all the social media stuff. We got the YouTube channel. If you are listening to a podcast and want to see some YouTube stuff, we do about a weekly video now on all sorts of different subjects. We have lecture videos, all sorts of stuff. So go check us out there. Check out our social media and look for more of these to come down the pipeline. We hope to make this a regular thing.
Where are these podcasts coming out where they can listen to them?
That's a good question. Wherever podcasts are found, hopefully. We're learning. We're learning. We're just a bunch of paramedics that do fun things, and this is one of those fun things we do. So no real training in any of this. I'm sure we'll figure it out. I would imagine Spotify, Apple Podcast, all the normal avenues. But if they're hearing this, they've already found it somewhere. So
Whoa.
Oh, Inception.
And with that, good night.